Well, it looks like we have the majority of our participants on today, so we'll go ahead and get started. Good morning and welcome to today's webinar. I'd like to review a couple of quick housekeeping items. First, this is a watch and listen only webcast. There's a chat button where you can submit any questions that you may have. We'll try to get to as many of these questions as possible during our Q&A session at the end of today's presentation. Following this webcast, we will be publishing a slide deck, a recording of the webinar, as well as a handout of all questions asked with answers from our speaker. You'll receive an email with the link to all this information in a few days. Additionally, at the end of today's presentation, a link will be provided for a brief survey. Please provide your feedback and input on future topics that you'd like us to cover. Now let's get started. Welcome to the Rybar Group's webinar, Getting to Know Medicaid, Program Basics and Reimbursement Opportunities. Your speaker today is Brooke Yall, our Manager of Medicaid Services. Brooke has extensive firsthand experience with the Medicaid program, including work coordinating with federal regulators, state legislatures, industry stakeholders, and other state agencies to resolve Medicaid-related issues. And she has proven to be very instrumental in negotiations with CMS to get new supplemental payment programs approved. Again, thank you for being here today, and now I'll hand it over to Brooke.
Hello, everyone. Thank you for attending. As we were getting set up, I just want to let everyone know my power went out and I am logged in through my internet through my phone. So if I get disconnected or anything, just bear with us and I'll get back as soon as possible. But again, today we're going to talk about Medicaid, Medicaid basics, and some reimbursement opportunities that are for some providers. So today's talking points, we're going to go over the overview of Medicaid, a little background on Medicaid, the eligibility, enrollment trends, reimbursement methodologies, funding basics, reimbursement opportunities, and go a little in depth into the supplemental payments. So first, just to start with the overview of Medicaid. And I apologize, it is not loading on my end. Claudine, can you see the next slide? There we go. Okay, there we go. So bear with us today. I apologize. I'm in Florida and it was 30 degrees, 30 something degrees this morning. So I guess the internet froze up. Something happened. So just to kind of give what's the difference between Medicare and Medicaid, right? So Medicare is federally administered, federally funded. It's healthcare coverage for people age 65 or older and certain people under 65 with disabilities and people of any age with ESRD. So the coverage is inpatient, that's your Part A, outpatient Part B, pharmacy Part D, and limited post-hospitalization. So Medicare is a primary payer. I think this is one of the big differences between Medicare and Medicaid. Medicare is the primary payer. Medicaid is a payer of last resort. So just, to go over Medicaid, it is state administered. Every state has a different Medicaid program. It is jointly state and federally funded. It's healthcare coverage for people with disabilities, elderly people, pregnant women, low-income adults, and children. And coverage varies by state. There are mandatory and optional benefits. And like I said before, it is a payer of last resort. So Medicaid, again, is a federal program through which states partner with the federal government to provide healthcare coverage to low-income children, families, elders, and people with disabilities. So the federal government establishes basic mandatory program requirements. States can then choose whether to participate in Medicaid, and it's jointly financed between the federal and state government. They both pay a share. Then the states develop their unique Medicaid programs based on federal rules, Each program must be approved by the Centers for Medicare and Medicaid Services, also known as CMS. So an extension of Medicaid is the CHIP program, the Children's Health Insurance Program. It provides health coverage to eligible children through Medicaid and separate CHIP programs. CHIP is administered by states according to federal requirements, and it's jointly funded by states and federal government. So just to summarize, let's say a child in the CHIP program, the reason that they're in CHIP versus Medicaid is, they might not meet the eligibility requirements for Medicaid, but they can go ahead and meet that eligibility requirements for CHIP. So they're enrolled in that CHIP program. And again, every state is a little different. So now we're going to go over the eligibility for Medicaid. So federal government requires states to provide coverage for the mandatory eligibility groups. States can choose to provide coverage for the optional groups. So some of those mandatory eligibility groups are the low-income families, qualified pregnant women and children, and individuals receiving SSI. One thing to know about pregnant women, usually it's a higher federal poverty level that they need to qualify for Medicaid. And depending on the state, usually it's about up to 200% of the federal poverty level. And if you weren't a pregnant woman, I think it's about 133% about that, depending on the state. So some of those optional eligibility groups are those individuals receiving home and community-based services, children in foster care, medically needy programs, 209B. These are just some examples. And again, every state is going to be a little different. And one statistic I wanted to note that I think is, I think it's a really great statistic, and it really shows the value of the Medicaid program. In the United States, Medicaid finances 42% of the births in all of the United States. So that's a pretty big statistic. Medicaid, they're really out to help everyone, and they cover a lot. So some of the Medicaid benefits, the mandatory services, these are the services that the federal government requires. So those are doctor visits, inpatient and outpatient hospital services, mental health services, prescription drugs, prenatal maternity care, preventative care such as immunizations, mammograms, and colonoscopies. And then some of these optional services. So these are the states have put in their state plan that they're going to also include these services. That would be dental services, home and community-based care, physical therapy, prosthetic devices, vision and eyeglasses. Again, these are just some examples of those optional services that would be available to Medicaid beneficiaries. So under the Affordable Care Act of 2010, states had the opportunity to expand coverage to nearly all low-income adults or low-income Americans under the age of 65. The federal poverty level was extended to at least 133% for children in every state. And they also had the option to expand eligibility to adults with income at or below 133% of the federal poverty level. So 37 states have expanded. I think that number is going to turn into 38 pretty soon. And then states can choose to expand anytime. So here's a map of the states who have expanded. So South Dakota, that one has expanded, but I believe they have not implemented yet. So they're in the process of that. It is a lengthy process to actually implement it. And then North Carolina has reached an agreement, and they are expected to be in effect by 2024. So we'll see one extra state that has expanded. And just in simple terms, I know I stated it previously, but when these states have expanded, they've expanded to that childless adult group. And so they were previously not eligible, but now they are eligible. So it is more adults that are eligible for Medicaid. So some of these enrollment trends, so there's currently 89, or as of June 2022, 89.4 million people enrolled in Medicaid and CHIP, 7.1 million enrolled in CHIP. There's 40.8 million children enrolled in CHIP or the Medicaid program, and that accounts for 45.6% of the total Medicaid enrollment. And enrollment has increased 26.5% since February of 2020, and that's as a result of the public health emergency. We will kind of go into that a little bit later. That is going to be changing here pretty soon. So there's a new act that was passed that we'll talk about here in just a minute. You want to just look at the map. So that is, if you look at July 2019 at the beginning, it was almost a steady, almost a declining Medicaid enrollment. And then once the pandemic hit, enrollment has increased, and no one is getting disenrolled from Medicaid, and that is why we're seeing that increase, steady increase. So the public health emergency is scheduled to end May 11th of 2023. So prior to the passing of the Consolidated Appropriations Act of 2023, the continuous enrollment condition was set to end at the end of the public health emergency. But now that condition will end on March 31st of 2023. With this new law, states can begin the process of terminating Medicaid beneficiaries that no longer meet the eligibility requirements starting April 1st of 2023. So states will have 12 months to initiate their work on renewals, and then 14 months to complete the renewal process once the state's unwinding period begins. So what does this mean for providers? Because of the conditions of the pandemic, we had continuous enrollment. That means states were not disenrolling recipients. There was a couple conditions, but they were not disenrolling anyone. So now a lot of those recipients that receive Medicaid, they're actually no longer eligible. They don't meet the eligibility criteria. So states are going to be beginning this process of terminating. And there's going to be a huge reimbursement impact because you no longer have all these, recipients eligible for Medicaid. They're probably going to go into uninsured or a different private insurance. So it's something everyone really needs to watch out for. States are beginning to develop their timeline for the redetermination process. And just an example, so Michigan did announce in the past week, there was a webinar yesterday. So the first alert letters are going to be mailed in March if they haven't already been mailed. The passive renewal in April. The redetermination will be mailed in May, and local offices will process redeterminations in June. And first cohorts of terminations will start on July 1st of 2023. So that's a pretty quick turnaround. Again, that reimbursement impact, that could really decrease your Medicaid reimbursement. But states do have typically a year or so. In some states, you might not see it that quickly. So I definitely recommend, depending on your state, get with your Medicaid program and determine if they have a process in place yet. Also, is there anything that you guys can do to help your patients either stay with Medicaid or kind of help them get to that next step of their insurance coverage? So next, we're going to talk about the reimbursement methodologies. So Medicaid reimbursement varies by state. There are two main delivery systems. You have the fee-for-service, that is the traditional reimbursement, and then you have managed care. So states can do one or the other, or a little bit of a combination of both. Typically, we see where it's a combination of both. So Medicaid payments have historically been below cost, and that is resulting in shortfalls. And so that's sometimes where these supplemental payments can kind of help you make up those costs that you're losing. So the fee-for-service, its reimbursement to providers comes directly from Medicaid. This is the traditional reimbursement. Each service receives a specific reimbursement in exchange for services provided. So it uses either a fee schedule or a base rate, and it is cost-based reimbursement. So typically there's a Medicaid cost report that's due, something where these, the providers are showing their cost and making sure that they did not get paid too much or too little. You also have a prospective payment system. So a couple examples, you'll hear the DRGs, the diagnostic related groups. That's typically for inpatient. And on the outpatient side, it's usually called an enhanced ambulatory patient grouping or something similar. And then you have the managed care delivery system. This is healthcare delivery system organized to manage cost, utilization, and quality. Provides for the delivery of Medicaid health benefits and additional services through contracted arrangements between state Medicaid agencies and the managed care associations. States pay a per member per month capitation rate to the managed care organizations. It is actuarially sound, and approximately 70% of Medicaid recipients are currently enrolled in a managed care organization. Some of the benefits of a managed care is it reduces program cost, it better manage utilization of health services, it improves health plan performance, improve healthcare quality, improves outcome, and providers negotiate contract with each MCO. And, on the state Medicaid side, it has helped administrative burdens that will fall on the Medicaid programs. So there's a lot of good things that have happened since the managed care has started. So Medicaid funding. So Medicaid programs are jointly funded through the federal and state government. So you're going to hear a couple terms when you talk about Medicaid. You hear the FMAP. That is the federal portion of the Medicaid expenditure. So the federal medical assistant percentage, or known as the FMAP, is used to calculate the amount of federal share of state Medicaid program expenditures. It varies from state to state, and it's updated annually. So the FMAP formula is based on the ratio of the state per capita income to the national per capita income. So it uses 3 most recent calendar years for which satisfactory data are available from the Department of Commerce, Bureau of Economic Analysis. The lower the state's average per capita income, the more FMAP and vice versa. And then all states receive at least 50% of the FMAP. Some are about 60%, but minimum 50% of the total expenditures does come from the federal government. So the total Medicaid spending was $748 billion in fiscal year 21, and that was including admin cost, accounting adjustments, and the U.S. territories. So the enhanced FMAP. So this was January 31st, 2020. The Federal Department of Health and Human Services declared the public health emergency. The CARES Act provides a 6.2 percentage point increase in federal Medicaid matching funds to help states respond to the COVID-19 pandemic. So the enhanced FMAP is effective, or was effective, January 1, 2020 through the end of the quarter in which the public health emergency ends, but that has changed. So as a result of the Consolidated Appropriations Act of 2023 that was passed in December, the enhanced FMAP was extended until April 1st of 2023, and then it will be gradually phasing down the increase until December 30th or 31st of 2023. And that act also amended conditions states must meet to claim that enhanced FMAP. So for the first quarter until March 31st, we're going to continue to see that 6.2 percentage. And then quarter two, so April to June, it's going to go down to a 5 percentage points. July through September, 2.5. And then our last quarter 4 is going to be a 1.5 percentage points until December 31st of 23. So those new conditions, in order for states to claim that enhanced FMAP, it will remain unchanged for the first quarter, so until the end of this month. But starting in April, so states must conduct Medicaid eligibility redeterminations in accordance with all applicable federal requirements, including renewal strategies authorized under the Act or other alternative processes and procedures approved by CMS. They must also attempt to ensure that they have up-to-date contact information for a beneficiary before redetermination eligibility. And then they must also undertake a good faith effort to contact an individual using more than one way prior to terminating their enrollment on the basis of a returned mail. So in order to get the rest of that enhanced FMAP until December 31st, states must do this. And I think that will also help, with this redetermination process. And, states are going to be able to follow everything so they can get that enhanced FMAP a little bit longer. Again, states that are accepting that enhanced FMAP until the 31st was providing continuous Medicaid eligibility, and that's why our enrollments have increased so much. Again, that is changing, and states may request to stop receiving the enhanced FMAP at any time without losing what they have claimed previously. And that is still, if they don't want to get that enhanced FMAP till the end of the year, then they can opt to not receive it anymore. So we talked about the federal, share of funding, and then we also have the state share of funding. So if a state has an FMAP that's 60%, the federal government is providing 60%. Well, where does that 40% come from? Typically, it comes from general revenue. Your claims payments, most of that state share funding is going to come through general revenue. Other sources are intergovernmental transfers, also known as IGTs. So that is the transfer of funds from a governmental entity other than Medicaid. So counties, healthcare taxing districts, providers operated by state or local governments, and that must be a bona fide donation. Other sources are certified public expenditures, also known as CPEs. So CMS requires cost reimbursement methodologies for providers using CPEs to document actual cost of providing services. Statistical time studies, periodic cost reporting, and reconciliation of any interim payments. Another source is a provider fee, also known as a tax or an assessment. So those must be uniform and broad-based to be allowable by CMS. It's a 6% maximum of net patient revenue, and that is on the inpatient and outpatient side. So healthcare-related taxes, they must be broad-based and uniform. That is, they must be levied against all non-governmental providers in a particular class, not only that those that accept Medicaid payments, and the tax rate must be uniform across all providers in the class. Providers cannot be held harmless through a direct or indirect guarantee that they will be repaid for the amount of the taxes that they contribute. However, the indirect guarantee test does not apply if the tax rate falls within a safe harbor established under regulation. The safe harbor is currently 6% of net patient revenue. So in 21, 69.3% federal spending and 30.7% state spending across the United States. So a couple of reimbursement opportunities. There's lots of ways that we can make sure that providers are at least getting up to their cost. So one thing about Medicaid is you cannot be paid more than your cost. So in order to increase cost, we want to look at a couple things. You can look at your Medicare cost reports, our Medicaid rate reviews. And on the next slide, we'll kind of talk about optimizing that Medicaid cost. But one of the biggest reimbursement opportunities is supplemental payments. And I'm sure everyone has kind of heard about supplemental payments, but really what are they? And we're going to kind of talk about that in a little bit, go over a few of the supplemental payments. But those payments are going to get you from, that Medicaid shortfall that you might be seeing all the way up to being paid your cost to providing services for Medicaid recipients and the uninsured. So Medicaid cost calculations per federal guidelines, like I said, providers cannot be paid more than from Medicaid, more than their cost for providing services to Medicaid and uninsured populations. So the Medicaid cost calculation, if anyone's familiar with the disproportionate share hospital program, and we do this audit, and the way that they're calculating cost, and a lot of times with the Medicare or with the Medicaid cost reports, they're using the Medicare cost to charge ratios. So are you optimizing those percentage? Are you assigning those charges to the appropriate cost centers? Although, Medicare and Medicaid are different, sometimes you kind of have to go back on the Medicare side to actually determine your Medicaid cost, and also go back on the Medicare side to optimize those Medicaid costs to make sure that you are accounting for all the costs so you can get paid up to your cost. Again, so how can we optimize our Medicaid costs, Medicare cost to charge ratios? And then we're allocating those cost to charge ratios in the correct department. So the biggest reimbursement opportunity is supplemental payments. And we're going to talk about the biggest ones, but this is what is going to, get you to your costs. It's going to fill in that gap of maybe that you weren't receiving before. So supplemental payments are Medicaid payments to providers that are separate from and in addition to the payments for services rendered to Medicaid enrollees. Payments are typically received in a lump sum and are not tied to services provided to Medicaid enrollees. The state share funding source is generally funded through non-general revenue funds. So like we mentioned before, IGTs, CPEs, taxes. They are authorized by the legislature either through statute or the General Appropriations Act and approved by the Centers for Medicare and Medicaid Services. So you can see them being approved by CMS through the 1115 waivers or state plans, depending on the supplemental payment and depending on your state. So about $40.6 billion annually is made through supplemental payments to providers, and that accounts for 7.2% of the total Medicaid expenditures. In various states, I've seen that growing, so I would expect to see this amount continue to grow. I think in states are implementing new supplemental payments on a regular basis, and if there's a supplemental payment that you're not seeing in your state, there's a good chance maybe they're working on it, or maybe that's a initiative that you as a provider can help initiate, because there's a lot of opportunity, there's a lot of money, and this could get you past that Medicaid shortfall that you might have been seeing in the past. So a couple examples of some supplemental payment programs. We have the Disproportionate Share Hospital Program, also known as the DSH. We have uncompensated care pools, low income pool programs. We have charity care pools, upper payment limits, directed payment programs, graduate medical education, Medicaid enhanced payments, ambulance services, and school-based programs. This is just a very, very short list of the potential supplemental payments that could be available in your state. These are just some of the biggest ones, and we'll talk about a little bit here coming up. So one of the biggest ones, is the Disproportionate Share Hospital Program. So DSH was created under federal law to compensate hospitals that have provided a disproportionate share of Medicaid or charity care services. Federal law establishes an annual DSH allotment for each state that limits federal financial participation, or FFP, for payments made to hospitals. So FFP is not available for state DSH payments that are more than the hospital's eligible uncompensated care cost. So, and the uncompensated care cost is the cost of providing inpatient and outpatient hospital services to Medicaid patients and the uninsured minus the payments received. That uncompensated care cost is what's calculated in the DISH audit that is done, 2 to 3 years after the payments are received. And it's those uncompensated care costs that use the Medicare cost to charge ratios to be calculated. So 13.2 billion total allotment for fiscal year 22. CMS releases the allotments around October of each year. And I just want to note some of the largest DISH allotments. So we have New York, it's 1.9 billion, California, it's a 1.3 billion, and Texas is 1.2 billion. So if your hospital is currently not receiving DISH, I would look and see why. Do you just not meet the eligibility requirements? Is there some form of a application that's due that maybe you're not turning in? Also, on the flip side of it, if you are receiving DISH and you've maybe historically been overpaid, why are you being overpaid? Those are all things that you want to look at, because the way that the DISH payments are calculated, they're using historical data, and really you should be able to retain all of that DISH payment. Again, it would be calculated in the DISH audit. So, and that is annually. So states are required to submit an independent certified audit describing DISH payments made to each DISH hospital. Any payment in excess of uncompensated care must be returned to the state. States have the option to redistribute or return to CMS. Depending on what state you're in, there are some states that redistribute. There are some states that do not. They just collect the money and return it to CMS. And Myers and Stauffer does conduct the most audits in the country. They're typically due around this time. So if you are busy with DISH audits, hopefully you're almost done, and hopefully you get to retain all of that funding that you did receive. So there are a couple new things about the DISH program. The Consolidated Appropriations Act of 2021. So not only it changed the calculation of hospital-specific DISH limits effective October 1 of 21. So probably next year when we're doing maybe in 2 years. So when we're doing the fiscal year 22 DISH audits is when that's going to come into play. So what it says is, when you're calculating these uncompensated care costs, historically, you're including costs from Medicare and those Medicaid other eligible. So if they have a commercial and Medicare or Medicaid secondary, you can include those costs and payments. Well, effective October 1 of 2021 or fiscal year 22, that's no longer going to be effective. So that is what's going to happen is during those DISH audits, you're only using where Medicaid is primary and uninsured. So no more of those extra costs unless you meet certain requirements. There is a caveat. I believe it's 97%, or if it hurts your hospital. There's Myers and Stauffer, I know, is still waiting on new rules to come out to kind of clarify. So, in the next few months or the next year, we'll probably be seeing more how that will actually affect the uncompensated care costs. But right now, those DISH payments that you are receiving should not include the projected payment should only include Medicaid primary cost and payments. This Consolidated Appropriations Act of 21 also eliminated the DISH reductions in fiscal year 21, and it delayed the remaining 4 years of cuts until fiscal year 24. So when I first got into Medicaid, they said that DISH was going to go away. And now we're in 23 and they have not gone away. So we'll see next year if we're going to see that $8 billion cut, or if they're going to delay it more. That can have a big effect if our annual allotment is almost 14 million. That's a big portion that will be cut. If your hospital heavily relies on these DSH payments, how is that going to affect, are you going to have an operational effect? So these are things that you kind of want to keep up to date, keep track of, especially if you heavily rely on those DSH payments. The Consolidated Appropriations Act also created new supplemental payment reporting requirements for states. So this is in addition to these DSH audits. So if your hospital is receiving an uncompensated care pool, graduate medical education, or any of these other supplemental payments, states have new reporting requirements. So we might see more audits. We might see more, payment reconciliations down the line, so states can meet this new requirement. If they haven't already started, at least with the uncompensated care pools, I know there's an annual reconciliation we'll talk about here in a minute, but just be prepared. Be ready if your state emails you and says another audit's on the way, just so you're not surprised, especially if you're receiving a directed payment program payment. So just talking about DSH, the reinstatement of CMS FAQs 33 and 34. So on April 30th of 2017, CMS issued a final rule withdrawing FAQs 33 and 34 from the Medicaid DSH guidance that was issued in January 2010, titled Additional Information on the DSH Reporting and Audit Requirements. So what that said is uncompensated care costs include only those costs for Medicaid eligible individuals that remain after accounting for all payments received, including Medicare and other third-party payments. So that is right now how the uncompensated care is being calculated for the DSH audit. As of December 30th, 2018, those FAQs 33 and 34 are no longer operative. And then states had the option to revise DSH audits to remove third-party payments for services provided before June 2nd of 2017. So you're including costs for Medicare and those Medicaid other eligible, but you did not have to include those payments. So when states redid these audits, a lot of providers who were overpaid were no longer overpaid. And this really helped because they were able to go back to prior DSH audits, and so that helped a lot of providers that were overpaid. Well, on August 13th of 2019, that final rule was reinstated for services provided on or after June 2nd of 2017. So that means third-party payments will now be included in the calculation of uncompensated care costs. And what that did, it reduced your uncompensated care cost. So if your facility receives DSH, and let's say in 2017 you were not overpaid, and then 2018 came along and you're overpaid, and you're like, we didn't do anything different. This is why, those payments were not being included for the 2017. And then 2018, there were several providers that were overpaid because now the payments are back in effect. In a couple years, we won't have to worry about this at all because Medicare costs and payments and those Medicaid other eligible will not be included at all. But if you're wondering why there was such a drastic drop in your uncompensated care costs, it was because of these FAQs 33 and 34. Now, if you still feel like maybe you're not including everything, that's something you want to review, and you want to make sure that you are including all of those eligible accounts. So another big example of a supplemental payment is the uncompensated care pool. It's only available in about 7 or 8 states right now, but it allows states to draw down federal funds to pay hospitals for care provided to the uninsured and underinsured. So it is approved through 1115 Medicaid waiver. So Florida, it's also known as the low income pool, got Tennessee, Texas, California, Kansas, Massachusetts, and New Mexico. So these typically are states that have not expanded eligibility to low-income adults, and there is an audit or reconciliation required to be submitted to CMS. and payments in excess of uncompensated care costs will be recouped from hospitals. And I do want to note for any Florida providers right now, the low income pool charity costs always used another reporting system to calculate the charity care cost, but now they have just switched that to S10. So they are using the charity that was reported on S10 to calculate those payments. I just wanted to note that that was new this year. So that's a pretty big change. The total spending in 2020 for uncompensated care pools was $8.2 billion. That's a big chunk of change. If you are in one of those states and you are not receiving this type of payment, definitely reach out to your Medicaid provider. You can reach out to us. We'll see why you're not receiving these payments. So just some charity care updates. The Health and Human Services can continue to use S10 to calculate uncompensated care payments. And, for Florida, for example, they were using the FIRST system. Now they are using S10. And I suspect that trend is going to continue with states across the United States. Audits starting with fiscal year 2017 cost report. So now, your MACs are really auditing what you're reporting on S10, your financial assistance, charity care, and bad debt policies. If you haven't updated them recently, I would go ahead and update, as much as you can. I would make that an annual process. And then our hospitals, including all appropriate charity care patients. So review and revise policies to maximize charity care claimed on S10 as needed. And what is the impact on Medicaid supplemental payments in the future? So just another Florida example, the initial low income pool allotment was based on the 2015 total S10 charity that was reported in 2015 that was reported. That's how they created that initial allotment. So CMS likes S10, especially now that it's being audited. So, in future years, I see them really relying heavily on what is being reported on S10 to calculate these Medicaid supplemental payments or to reconcile these supplemental payments to what's being reported on S10. So it's just really important to make sure that you are, optimizing what's being reported on S10. You're getting through these audits and, you're really taking an extra couple days to really focus and what are you putting on S10? Because it's going to not only affect your Medicare side of things, but also the Medicaid. So the upper payment limit, also known as the UPL, so those are lump sum payments that supplement low fee-for-service base payment rates. If base payments are below the UPL, states can make UPL supplemental payments to make up the difference. So these are payments to hospitals, nursing facilities, physicians, and other providers. So in the aggregate for a class of providers, fee-for-service based payments and UPL payments cannot exceed a reasonable estimate of what providers would have been paid according to Medicare payment principles. So those are classes of providers that are based on ownership. States do not use actual Medicare payment rates when calculating the UPL. And some providers can receive UPL payments that exceed what Medicare would have paid, as long as the total payments for each class of providers are below the UPL in the aggregate. So they look at really the classes. And currently it's about $15.3 billion that are distributed annually, and about 35 states have a UPL program. The UPL demonstration requirements. So in 2013, CMS issued guidance requiring states to demonstrate compliance with the UPL requirements. So states submit hospital-specific data to CMS in a standard format. So Medicaid fee-for-service base and supplemental payments are included on that report. It estimates of what would have been paid according to Medicare payment principles. And again, some hospitals paid on a cost basis, such as critical access hospitals, are not included. So another big supplemental payment is the graduate medical education program. So Medicaid provides the second largest source of GME funds. States follow broad federal rules to receive federal matching funds, and then states have the flexibility to design and administer their own programs. Payments can be made through fee-for-service, managed care, or a combination of both. And there's direct and indirect programs. The Medicaid GME payments help support teaching hospitals. These institutions' higher costs can reflect both the direct cost of training as well as the indirect cost of training associated with a more severe case mix. Some states make GME payments as supplemental payments, while other states account for the GME cost in the calculation of a base payment to teaching hospitals. So it really varies, state to state. But currently there are 43 states that have a Medicaid GME program, and it provides annually about $5.5 billion in funding each year. And, there's a lot of flexibility with these GME programs. If you're a statutory teaching hospital and you're not receiving any GME payments, maybe there's something, and your state has one. Maybe that's something you want to look into. Why are you not receiving this? Even if you're not a statutory teaching hospital, but you have a large teaching program or, medium size, there's a lot of funding opportunities here, and that can not only help you with your resident cost, but that could help you kind of fill that gap, that Medicaid gap. So another program is the Directed Payments Program. There's kind of different names for it. You might hear a pass-through, like a Medicaid pass-through payment, but it is a directed payment program. So it is an additional per member per month made through the managed care organizations. So the per member per month is based on Medicaid utilization. So this is typically approved by CMS through a 438.6 preprint. It's actuarially sound, and it does require providers to submit quality metrics to states to substantiate the additional payments. Hospitals are receiving these physician groups. There's a lot of flexibility, and there's huge opportunities to receive additional funding through these programs. And then states can also implement something similar through the fee-for-service delivery system, and usually that will use like an average commercial rate to calculate that enhanced payment. So CMS really likes these right now. They like them because these providers submit quality metrics. They are substantiating why they should receive this extra payment, and you can track it back to utilization. Some states make these monthly, some it's a lump sum, but it's typically, they calculate the payments based on that monthly utilization. So I am going to open the floor for any questions. I know that was a lot of information to take in. So if you have any questions, feel free to go ahead and put that in the chat, or feel free to reach out to me after, especially if you have any state-specific questions that, I can help you with. More than happy to do that. And my contact information will be at the end. Right. I don't see any questions coming in. Just to go ahead and put out, we do have our Medicaid services. So with that, we do DISH uncompensated care pool audit, supplemental enhanced pool payment optimization, settlement and upper payment limit issues, prospective payment rates, special designation requests, Medicaid appeals, and charity care financial assistance optimization. So if you have any issues with your Medicaid reimbursement, feel free to reach out and see if we can help you. So, and then at the Rybar Group, we know that healthcare reimbursement is hard, but we strive to make it easy, allowing providers to focus less on administration and more on patient care. We develop tailored solutions that work within our clients' operations and culture. We offer a range of reimbursement and revenue cycle optimization solutions designed to identify opportunities for revenue generation, isolate root causes of underperformance, accelerate cash in the door, and support long-term margin improvements.
Brooke, it looks like we did just have a question come in. We were being asked if we have any information on the PHP program.
Todd, I can reach out to you. I'll see exactly what state you are with, but I don't have any additional. But I can reach out and we can have a conversation.
Great. Well, it looks like we do not have any additional questions. So this concludes today's webinar. Thank you so much, Brooke. That was a lot of great information. Everyone, please be sure to take a few minutes to complete the survey using the link that I provided in the chat box. We did have a couple of questions. You will be receiving a copy of today's slides as well as a copy of the recording of the event. That will be sent out in the next few days. In the meantime, if you have any questions, give Brooke a call and she'll be able to help you. Additionally, we'd like to invite you to our next webinar, which is going to be April 18th, and it's Your Roadmap to Success, How to Open a New Practice Step by Step. This is going to be a great webinar, whether you're opening a new practice or if you have a practice that is looking to expand. Other than that, thank you so much for joining us and enjoy the rest of your day.
Thank you, everyone.